Good morning, everyone who joining us. You can write on the chat. I think it's available right now. Yes, it is. I'm seeing people saying hello. We have people from different countries, so it's really a pleasure to have everyone here in this morning. We are just waiting 2, 3, 4 minutes before we start and have everything settled to move. We have a few changes in our program for today. Professor Yasser, it will not be possible for him to join us. We will have the same lecture, but it will be Elsa who will talk about that specific topic. How it was to prepare the topic in just a short period, Elsa.
It was challenging, but as it is a very interesting topic, it was great. So it was a new opportunity to keep improving.
So this morning, this meeting will have a duration of 2 hours. And you can all interact using the chat box that when we will come back to you, or during the lecture, we can answer some question or some commentary, or at the end, we can do some comments. So probably I will start so we don't lose too much time. And I want to say thank you to everyone and to my colleagues who helped me to prepare these events. This month, October, we have a lot of conferences, lectures. It's amazing to see how the Stuttering Awareness Day, it's now transforming in a Stuttering Awareness Month. And we see so many lectures, conferences, symposiums about the topic, and that is great. Our idea was also to bring our experience, what we have been working for this last year, some topics that we really believe we should address. So that's why we organize this event, is to share what we are working at iStutter and speech care with colleagues from different parts of the world. So it's exactly this context. We also want to thank to our partner, Stutter UAE, who help us to advertise this event, because the idea, this specific meeting, it's really focused on more technical issues to speech therapists, but people from the community are always welcome. And I really believe in this connection between professionals, research, community. So for me, it's really important to be in touch with everyone. So again, thank you so much. And you are more than welcome to share with us some ideas and thoughts in the chat box. Last weekend, me and Elsa had the pleasure to participate in the conference of the Saudi Arabia Speech Therapy Society. It was a huge pleasure and also a challenge to think how culture can have an impact on stuttering. And that's why I really enjoy these meetings with people from different countries, because we can explore and compare our experiences. So please, I want you to participate, to interact with us. If we have the chance, we can also give a voice to some people to participate. And that's what we want to happen today. So I will start to share my screen and start my topic. I choose this specific topic, how innovation can help to cope with the daily challenges of stuttering therapy, because I don't know about you, but I face a lot of challenges in stuttering therapy, and in the end of the day, I have a lot of doubts that I bring to my team and to home, and I'm always thinking how we can solve or how we can deal with this with better tools. So this lecture, it's to share with you some of the tools that we have been working, some of the tools that I know other groups are working, and of course, I want also your feedback about our needs as speech therapists or other professions who deal with people who stutter. I have a disclosure to make, because one of the projects, it was funded by European Union, so I need to do this disclosure when I talk about it. And I want to start, of course, to explore what stuttering is, of course, in a very short version, because we don't have that much time. But as we know, more and more, we are leaving the paradigm of this fluency and think about stuttering with only a moment, and we think as an experience. So it means, and this is based on the International Functional Classification, and I know Elsa will explore this deeper in her lecture, so I will go like in a shortcut. We know how the experience of stuttering it's so much more than the disfluency. We know it can start before the interaction, so how people are thinking and feeling about a specific situation that they will face. We know they can struggle, they can do avoidance. We know it can affect the cognitive, how people are thinking, the self-image, self-esteem, can have a huge impact on feelings, emotions, and we know how shame and fear can really be something difficult to handle in therapy, and how anxiety also can do big problems or barriers in therapy. We know, and I believe everyone struggles with this, how variability, it's difficult to measure and to control. And I'm quite sure you all have the problem, how can this person who do it beautifully in the clinical setting can do the same thing in real life? Because the truth is, the way we can measure severity of stuttering is through the impact. And if you have someone who is very functional in a clinical setting, but still struggling in interacting with people, connecting, sharing, participating, so we are not being successful in our therapy. So these are a lot of challenges that are influenced by environment, by context, by family, school, society. So that's why stuttering is so complex, and there are so many variables that we need to control. And I believe it's a challenge for all of us in therapy. So my question for you, I want you to write, what are the major problems that you struggle in therapy in your daily life, in your clinical setting? It is variability, it is working with families, is to know what is going on outside of the clinical setting. People don't do what you want them to do. So please just write a sentence or words about the problems that you face on your therapy. I see people with hands on, but you can write on the chat. I think the chat is available right now. Yeah. Okay, we have some answers, and I will say it loud. Some denial from patients and parents. That's true. And sometimes it's really difficult for families and people who stutter to understand the characteristics of stuttering. Something that we need to keep in mind when we are working with someone who stutter, we as a clinicians, we can know more about the science of stuttering, but the person is the specialist about his own experience. So we really should validate what they are feeling and thinking, and of course, manage expectations and understand it's a process. It doesn't need to be right away. So let me see more things, because you have a lot of answers and that is great. The personality, okay, that affects treatments. That's true. That's why treatment need to be very individual. That's why also one approach doesn't fit all. So we know that. Knowing what's going outside of the clinic, Dana is telling us that it's difficult to know what's happening outside. And sometimes we only have the perception of the person or the family of the last week. And this is difficult. To carry techniques with the patient, Arthur is saying. So the patient probably sometimes they don't do what we tell them to do. You know, something that was really interesting. I participate in a research the research was measuring how much time people practice and how they improve. And we saw, of course, people who practice more improve better. That's not, it wasn't weird, we found that. But the nice thing that we found was the perception of people who was practicing like literally less than 15 minutes per week, their perception was that they practice the same that people who was practicing a lot. So it was really interesting to see that people doesn't have the perception how much they are practicing. So we should think about that. So shaming from relatives and employees, complex social environments, so doing transference from clinic to difficult situation. Most of children, parents are working with client struggles to generalize the skills and the therapy at home setting. Okay, and that's good. We have so many answers. Yeah, so there are a lot about generalization, understanding stuttering nature, helping strategies outside of the clinic. Some of them, they prefer tablets to recover stuttering rather than exercise. That's nice, Noor is sharing with us. So like we can see, a lot of the problems that we struggle, it's about people understand what stuttering is, acceptance about some of the information that we give, how to take therapy outside of the clinic, how we as speech therapists can involve more people in the therapeutical process, give more structure. How can we know more what is going on outside of the clinic? Because as we know, variability can take a place in stuttering therapy. So based on all these problems, I think technology can help us. I really believe technology can help us. Teletherapy, all of us had a huge experience during COVID. So it was something that we have data that show people was very, I will say people didn't believe that teletherapy can be a tool. And after COVID, I think we have a different perspective. We still need to learn a lot about it, how to make it more efficient, but we know it can be a tool. I think something really interesting with teletherapy, we start to understand better the familiar context of the people that we work with. I really believe that you all saw how some of the kids that we have in therapy, how is the familiar context, how families interact with them. Then we have digital therapy that I will explore what it is. We have virtual reality, VR projects are now growing in our field, and that's good news. And I also believe that technology can help us to have more resources for learning, like this specific moment that we can be here and discuss about stuttering, or we can take a stuttering course on a workshop or a conference, or I can have a place that I have knowledge, that I have research, I have papers, or I have the description of techniques, or I have materials to use. So I think technology can also play a role. So what is digital therapy and how it can be useful and how it will serve us in therapy? I believe one of the limitations that you all have is you are with your client, I don't know, 1 time per week, around 50 minutes. That's less than 1% of his time. We struggle a lot to people understand some of the exercises, some of the techniques, and practice at home, because we know in the clinic, short memory is working. They got the exercise, but then they go home. They don't remember how they can do it, how to measure if they are doing properly. We don't know nothing about it, how much time they practice, how it was, how they felt. So there's a lack of data for us to understand what is really going on. And we know that therapy is based on neuroplasticity, and neuroplasticity is based on practice. So this is a problem. And what digital therapy wants to cover is not just in the session to support you to collect data, but between sessions, what your client is doing outside of the clinic, you will receive data about it, or you'll receive more feedback about how he's doing. And this can help us to accelerate the therapy process, and it can help us also to have better results. So the major idea is a continuum of care, not just in the clinical setting, but like when one client was telling me, I want that technology allow me to have my therapist in the pocket. So that's exactly what digital therapy is about. How can we be in the pocket, but without being invasive? How can we be in the pockets, but without the person become obsessive? Because, of course, therapy is a small part of his life. So these are some of the challenges. I want to talk with you about Benetalk. It's a project to help people to do transference, like you said. This specific project, it was designed to provide feedback about speech rate. We know some of the techniques or some of the approaches they use, they work a lot about speech rate, but for the person, self-assessment on her speech rate, it's quite hard. It's really difficult to do. So they developed a speech algorithm that he's in a mobile, and the person is talking and can receive on real-time feedback. It can be visual, like you see, it's changing colors. Green, it's considered a normal speech rate. When it turns yellow, it means that the person is accelerating, and red, it means it's talking too fast. So the person can receive a visual feedback or a tactile feedback. It can vibrate, or a sound, kind of beep, when the person is accelerating. One of the challenges of all these systems who work with speech automatic detection, it's the surrounding noise. So they are working because imagine if the system is catching the noise of the car, on the coffee shop, on school, it will not work properly. So they all are trying to develop this algorithm to become more reliable and only focus on the voice of the person. Google Health also have an amazing project on speech, language and communication disorders. It's called Project Euphonia. You can take a look on that online. They are working with several disorders. They have clusters for each condition. And I was very happy to participate also in the stuttering cluster. And they are also developing a system that can detect automatically speech and do analysis, or in case of people who cannot have people with neurological conditions who cannot articulate properly, you can have like subtitles when people are talking so others can understand. So it can be in the future a tool for us to use in therapy to measure speech samples. I remember in the conference this weekend, someone was saying, I really want a system that do an automatic analysis of all my assessments, because it takes a lot of time to count syllables, analyze types of this fluency, duration. So it will be amazing if you have a tool like that. I believe we are close to have that. And imagine this, the man already went to the moon and we still don't have this kind of tool. Imagine how complex it is. It's really complex. because speech is complex. We can put it in a simple way, but it's not. It's a really complex process. And these programs, they are also complex, but it's really good news that we have people working on this. Others specifically for stuttering that I want to share, because it's a project that I really enjoy, and iStutter is collaborating with them, testing the game. It's called Fluency Friends. It's digital therapy. And this is an amazing example what digital therapy is. So this is a horse, is a game controlled by voice. The joystick of the game is your voice and your speech. And this horse will go for an adventure. He's traveling through different islands. And you have speech tasks to do that are speech exercises. And what the game does, it's measure how is the practice of the person and provide the data to the therapists. So it means you have your access from your own side that you can watch how is the percentage of efficiency, I don't know, in soft articulatory contacts or on smooth speech or whatever the game is exploring, but you'll receive that data. How was the week of these kids during his practice with the game? So you know what he struggled more, what is easy for him, how things are going. And of course, he's having a lot of fun. And we know this can help people to be more engaged with the therapy and with the exercises. This game it's quite nice. They are still developing. It's a colleague. He's a speech therapist and an engineer, a speech processing engineer, and he has his own team. Sorry. And the interesting thing is it combines speech exercise, some mindfulness exercise, and a lot of information about stuttering, because we know how cognitions are important to change to have better results. So it's a nice tool to take a look on. And we know how important it is to have more tools and how important it is to have things, like I was saying, that digital therapy is a continuum of care. People who stutter also need this continuum of care, because some data, like this Germany study, show us that usually people who persist on stuttering, they have comorbidities, so other conditions or disorders combined with stuttering. And usually we know that stuttering, it's not caused by a mental health disorder, but we know that unfortunately, people who stutter and persist, sometimes they develop some mental health disorders. And if they have another comorbidity, they are in a higher risk to develop. So keeping that in mind, more and more when we assess, we know that, for instance, kids who stutter, we can see some changes on executive functions. We see these kids usually have a higher score on ADHD tests. There's a subtype, let's say, of kids who stutter that research show us they stay longer in therapy. That therapy, it's harder to provide. Katya and Anna will talk about it, so I'll not talk about it. And we know that when these kind of disorders are combined with stuttering, some of these kids can be adults with social anxiety disorders or others. And we also know about nature of stuttering that involves basal ganglia. Sometimes we have other neurological conditions associated, like Tourette syndrome, tics, or others that can make therapy harder. I focus on social anxiety disorder because they have a huge impact on adults who stutter and how it interferes with participation, how it increases avoidance, how it brings pain, and have a huge impact on quality of life. And we also know that social anxiety disorder can have a huge impact on therapy, not just because it can be a strong limitation, but because it also can bring relapse. So one technology tool we have available for free, it's called iGlib. That is a program that you can use with adults who stutter combined with your own therapy. Because like we can see that it's common that people who stutter and have a mental health disorder are more propense to relapse. So this is something that we can cover since right now. So what is virtual reality in speech therapy, and how it can be useful for us, how it can change your struggles with variability, and our struggle to measure variability in our struggles to make transference? Because we can do role play in a clinical setting, but it's not exactly a job interview or talking to an audience or a difficult negotiation. So right now, we have virtual reality for several conditions or disorders in speech therapy. We have in dyslexia, in aphasia, in autism spectrum disorder, and also we have in stuttering. More and more research on VR on stuttering, and we have a pretty recent paper who do a systematic revision of all the research we have about the topic, and I really recommend you to read it if you want to use it and to know more about it. But what you really need to know for VR, we have two kinds of VR. We have VR generated by video, that's VGI, and we have VR who are actors who is shoot scenes. So we have research that show us that VR with VGI, it can trigger the same level of anxiety and the same stuttering severity that the real scenario, so the real situation. Was a research with adolescents that it's quite nice, because you can see in the clinical setting what people are experiencing in real life, and in a safe place you can work whatever the kind of therapy you're providing. So our team developed a prototype. This is something that I want to show you of VR, and it's filmed. So we use immersive VR because we believe that actors in 3D can be more real. We can be more consistent in the scenes that we are using. We can trigger a stronger biological response, because the facial expressions, the human facial expressions, can really activate and trigger more emotion. And of course, the idea is to recreate what people experience in real life in our clinical setting. So what we used was the VR, and we also used some biosensors. In this case, we use ECG, but in the future, we want to use eye tracking too, to know exactly where people are looking for. And what we did was we worked in a job interview scenario. So basically, we recreate an experience when the client can go to a job interview. So it means he will wait in the line, talk with the assistant, say what he wants to do, where he wants to go. And of course, as you can see, the assistant, it's not the pleasant person on world. So we, of course, the actors, they were prepared to have an expression not that friendly, to increase some emotion and some challenges. And then we have, during the experience, we trigger more emotion. It starts with one-to-one interview, and then it goes to a group interview. So to give you a sense of that, I brought a video to show you a little bit what's happening, but the system collects the data so we can analyze after that. But I will show you the video first. The sound is working. I don't know if the...
71 million.
Let me share again. Probably I didn't put the... Yeah, now it sounds.
People stutter worldwide, which is equivalent to 1% of the population.
So stuttering, it's a neurological condition that affects the flow of the speech production. It means that the person is talking and can experience a feeling of losing control. And it can have a major impact in their lives, in social, professional, educational, because communication is everywhere. One of the major challenges in therapy is what we call variability. It means that a person in one specific situation can be very stuck and it can be very hard to talk or not talking at all. After some moments, he can be totally fluent. And this is a major challenge because it's dependent of the context, it's dependent of stress, other variables. So it's very difficult to measure and to do the appropriate treatment. Today, the way we assess stuttering is in the clinical setting in a specific moment with direct observation of the symptoms. These have a strong limitation because it's just one moment. We are missing the other situations that variability can cause an impact. On the other hand, we use self-assessment questionnaires. It's the perception of the patient. It's useful, but at the same time, sometimes there is a huge gap between the perception and what is really going on. Our proposal is to develop a tool that can replicate different situations that allow us in a safe environment with the use of a VR headset to catch exactly what the person experienced in real life. And with that tool, we can analyze exactly and measure in a very detailed way what is going on, and with that do a precise diagnostic and a treatment plan very individual to that person, but also to analyze the progress of the treatment.
All the scenes are made of videos that are viewed through a VR headset, and each video sequence is 180 degree wide. It covers half a sphere and is shot in 3D. The 3D effect really improves the sense of realism and the feeling of presence of the user in the scene, especially when the actors are at the right distance from the camera. We opted for video and real actors instead of avatars evolving in virtual environments. Both are fine, but immersive videos enabled us to reach a higher degree of realism, especially when it comes to facial emotional expressions of real actors, which ultimately contribute to trigger emotions in the users. Everything is scripted to generate a progression in the experience, from easier situation to more stress-inducing moments. For instance, the job interview experience starts at the reception of the company and finishes with a scene in which two more actors that were not expected by the user walk into the room and join the main interviewer for what ends up being a group interview with more challenging questions.
Okay, so this can give you a sense about how we build this kind of project, how we can build the scenes, and of course how we can collect all the data what we want. Something that iStutter developed, in fact, is an iStutter app. Like we discussed, how can we know what is going on at home? How can we receive feedback? For instance, if it's a family, if it's a child, how can we know how the practice is going? How we can assess severity? So we use severity ratings, so people, parents, or a person who stutters can score himself and we can know exactly what is going on. We can also rate like the special moment. If you're using special moments of interaction between the child and the family, and so people can score and send us videos or write some notes about how they are experiencing. So we can have a progressive view about what is happening, what is going on. We can correlate different variables, and also family can check their own progress, or the client can check his own progress during time. Of course, all this data need to be in just one system, and that's why we developed our platform that not just is used on the therapy in the sessions. And the way we thought about the platform, it's exactly like I said in the beginning, it's just not helping us on teletherapy or on-site therapy. It's also collecting and the data that people send us during the week, so we can put it in our clinical rationale, but it also helps us to take clinical decisions. It helps us to know in which area we should focus more in our therapy, and of course it allows our professionals to have more resources for work. So this also is helping us to develop and contribute to some clinical trials that is being developed right now about medication that I think in the future will be available for some people who stutter. We are very happy to work with our clinical medical director, Dr. Gerald Maguire. So I really think that the future will bring us is all this data. It's just one place. AI and machine learning will play totally a role. Pathological voice identification will continue. So I hope in the close future, our system, our app have something as pathological voice identification. And we really should think that we are living right now a revolution in the way we work, in the way we provide service. Technology will play the role, but to collecting data to help us to take the right decisions or to be faster in our treatment or to be more accurate on the individual needs of each person. So to finish my lecture, we have more evidence on the impact of VR in stuttering therapy. And right now there's some research about digital therapy also about accuracy in treatment. We have more and more projects of technology applied to stuttering. That's really good news. We have grants from European Union, from US, from other countries who are investing in this field. We need to bring more SLPs for the development. It's really important we be involved on this. And of course, research. And I don't think we should have afraid of technology, because I really believe technology will be a tool to help to collaborate with the SLPs. Some groups in the past, they thought that technology can substitute SLPs. I really don't believe on that. So just to finish my lecture, and I can see if you have some questions, and if you want, you can put the questions in the chat. If you want to know more about stuttering, we are happy to start now our second edition of our course. We already have done the first edition. I saw in the attendees some colleagues who have done our course, and I'm really happy to see them here and to receive the feedback and how engaged they were with our course. For this special occasion, we are giving 10% of discount for people who are participating with us on this event. So you can use the codes that we have it here. And like I said, we can use technology as a center of resources. And this course is exactly one example of what we can do and how technology can be helpful. And just to finish, because like I said in the beginning, I really believe that we are a community between people who stutter, therapists, families. I know that in UAE, and I believe in Saudi also, some events will take place, but particularly in UAE and organized by Stutter UAE, on the 22nd of October, it will be the Stuttering International Awareness Day. And I know that Stutter UAE prepare a huge event in an amazing place with a lot of activities. And I believe we as speech therapists have the responsibility, not just to involve and to provide information to our clients about the community that exists and people can take part of it. And I also think we as speech therapists, we should participate in these kinds of events. So please take a look on the Stutter UAE page, see the event, and I'm sure you will love to participate. I have the chance to participate in the past, and I love it. And I really recommend to everyone. So I don't know if we have too much time for questions. I saw here what was the code. Maisa, I will put it here on the chat, the code and the information, so you can take a look. The app, some of the apps are available on iOS. Arthur, our app, it's not available yet. And for now, we are using it just for internal purposes with our clients. But I hope in a close future, at least one version of it, we make it available for other colleagues can use with their clients. But we'll be in touch and we'll share with you for sure. So thank you so much to follow my lecture. I see Mona have a question. I will give you so we have 2 minutes for the question. I don't know if it's okay, Mona. Yeah, I'll give you the mic and I don't know if. Hello? Mona?
Yeah, sorry, I pressed it by mistake.
Oh, okay. It's okay. No worries. Sorry. Thank you. Very good. So thank you so much, everyone. And let's move to the second lecture. And I have the pleasure to introduce Elsa Soares. Elsa is based in Abu Dhabi. Elsa had her PhD on early intervention, and she is the research and developmental manager at iStutter Center and Speech Care Innovation Center in UAE. And Elsa will bring us a very important topic. Elsa, can you share with us what will be the topic?
Of course, thank you, Gonçalo. I am the lucky one because I am lucky to work with this wonderful team. I'm always learning with all of you, so this is a great challenge, and I will share my screen. Okay. You have to give me permission.
Right? Okay. Yeah.
Thank you. Thank you. See. Hello, everyone. Hope to find you well. And it is a great, great pleasure to be here in this second edition of Stuttering Talks. And of course, it is also an honor to have you with us so that we can discuss together, learn together about important issues in order to keep bringing our profession and our practice in stuttering assessment and intervention to the highest standards possible. Today, we set out to bring this challenge of talking about evidence-based practice and stuttering. When I was thinking about this theme, I thought that there are a lot of important aspects that must be discussed. And to approach these aspects, I started to pose questions to myself as a speech and language therapist, of course. When we are talking about evidence-based practice, are we sharing the same concepts? Are we sharing the same framework? So, as speech and language therapists, we know that how communication can be affected by misunderstandings or different states of mind regarding the same issues. Of course, that most of us will have different perspectives and different opinions about the same themes, and that is completely okay, and that is totally enriching. But we can only discuss properly if we set the stage for a shared understanding. So, in fact, let me change here my, okay. So, in fact, evidence-based practice is complex, is broadening, and is challenging, but it is very much needed in our practice. So, as it is stated by the American Speech Language Hearing Association, our very well-known ASHA, evidence-based practice involves the integration of the expert opinion. And when we're talking about expert opinion, we're talking about our knowledge, our judgment, our critical reasoning that is acquired not only through our training, but also through our professional experiences. Then we have to explore the external and internal evidence. Here, we must explore the best available information that we gather from the scientific literature and, of course, the data that we gather from the observations that we collect on our person, the person that we are, the person who stutters, the caregivers, the families. So here, of course, we are talking about the internal evidence. Then we must not forget to have into account the person's perspectives and the caregiver's perspectives. So these people have a unique set of personal and cultural circumstances that we must identify and that we must respect. So when all these three components of the evidence-based practice are considered together, only then can we as speech and language therapists make evidence-based decisions and provide high-quality services reflecting the interests, the needs, the values, and the choices of the person who stutters. And of course, as Gonçalo has said, we come here a lot of times to talk about these schemes. So when we talk about collecting this internal evidence, when we talk about the person's perspectives, we must think about the paradigm that is widely defended by the World Health Organization. And here I am talking specifically, just as Gonçalo talked about, I am talking specifically about the International Classification of Functioning, Disability, and Health, ICF. So when we think about stuttering and when we deeply understand its complexity, we must think, as it is widely defended by research too, that we have to collect information regarding these different and interrelated aspects that will also have an immense impact in stuttering intervention. So we are talking about gathering information regarding body structures and functions, personal factors, environmental factors, and activity and participation. Of course, it would be very interesting if we have now the time and opportunity to discuss this, because this is so interesting. But as I only have 20 minutes, let's keep, and maybe if we have time, we can discuss this in the moment of discussion. So, as we know, evidence-based practice is a versatile, is dynamic process of applying current best evidence. And of course, the evidence regarding external and internal evidence, as I have said, and the person's perspectives and the clinical expertise to make decisions about the intervention process. So, when we talk about evidence-based practice, we know that the first step is to identify the problem for which the team is seeking evidence. And when I talk about the team, I am talking about the speech and language therapist, I am talking about the person and all the important communicative partners, and of course, other health professionals that may be part of this person's life. So stuttering intervention, as Gonçalo said, is a collaborative process where we need everybody and we need also the environment. So in this first moment, it helps to pose a focused and relevant questions about the person's situation, once it will guide our search. One widely used approach to frame this question is known as PICO, which stands for P, population, I, intervention, C, comparison, and O, outcome, regarding, of course, the person who stutters. So then we have to gather evidence. So when we talk about internal evidence, we talk about systematically collect data directly related not only with assessment, but also with intervention process, so that we are able to ensure that the person who stutters is making progress and their significant relatives are being empowered regarding feelings and attitudes. This data may include assessment that is done across the time regarding stuttering, communicative performance, attitudes of communicative partners. Of course, that we have to use our expertise and our clinical reasoning to define the information that is most important to track the person's specific situation and needs. Having into account this internal evidence, we are better prepared to find the right external evidence that will help the team to make the clinical decision. So when we talk about this external evidence, we are referring to evidence from scientific literature regarding the state of the art. This evidence is crucial to guide the definition of the best intervention approach and service delivery model, so that we can really be effective, having an impact in our intervention. After collecting this evidence, now we will have to analyze it. And when we analyze the internal evidence, we are determining whether an intervention has impacted the person. So at this point, we can ask questions regarding assessment. Am I doing the best assessment possible to this person who stutters? Is this assessment individualized to the needs of this person, caregivers, and environment? And we can also make these questions regarding intervention. Is the person who stutters demonstrating a response to the intervention? Is that response significant, especially for this person? How much longer should we continue the intervention? So we make these kind of questions so that we can address if we are going on the right path. Then, analyzing the external evidence, we want to answer our clinical questions, and such as, for example, if our assessment measures are the right ones, if they are measuring what we intend to measure. So, because the quality of external evidence is variable, this step of assessing the evidence is crucial and includes determining the reliability, the importance, and the applicability of the relevant scientific research to our client's condition and needs. And then it comes the moment where we have to make the decision, the team decision. This will not be a decision of the speech and language therapist alone. Again, this is a team decision where all people are involved. So this final process requires that we can make a clinical decision. So to make an evidence-based decision, we have to, as we said, consider the evidence. And also, a very important thing, we have to assess the appropriateness of our clinical experience for the situation and review the person's priorities, the person's perspectives. So when we are trying to make this decision, maybe this framework, decide, can help us in this process and can help us to reach to this decision. When we're talking about define, we have, of course, first of all, we have defined our clinical questions, we gathered the internal and external evidence, and we determined the validity and trustworthiness of the results. But we know that some results will be directly applied to the person and to the setting, but there will be situations in which we have to determine if the overall results are compelling and meaningful enough to apply to that situation. So we know that sometimes there is a lack of external evidence about our clinical questions. And if there is little or no external scientific evidence, then our approach isn't necessarily disqualified. It just requires careful consideration and monitoring. This is the point where we have to extrapolate. So we will, if we don't find the right evidence that supports our approach, because evidence was not developed yet concerning that approach, we know that we have to make a careful consideration and monitoring. Then, of course, when we consider, we always have to consider our clinical expertise, but we must not forget that we also have to consider the expertise of our colleagues that may be crucial in the clinical reasoning process in the discussion of a specific study case. We have to incorporate the needs and perspectives of the persons, their caregivers, the family, and we have to incorporate this in our assessments and our intervention. And of course, we have to develop an assessment intervention plan by bringing all of these that I have said together. So, and then we will evaluate our clinical decision. We will maybe use a trial period, collecting this internal evidence, analyzing, so that we can be always in this dynamic process of adapting the intervention process if it is needed. We know that a lot of research is being developed in stuttering, and this has a great impact in the development of best practices. Taking into account the specificity of evidence-based practice, we can also find some articles that allow us to reflect and discuss some important points. In this article from Ratner, in which some results of a forum developed by the Journal of Fluency Disorders are discussed, and this forum pertains to the status of evidence-based practice in fluency disorders. The author states that there are stuttering treatment approaches that are validated by analogy to other disorders, and that despite the operant behavioral treatments have a very large literature concerning effectiveness, the author states, and now I am quoting, that the derived from such treatment approach do not represent the only decent evidence out there. And here we say that some authors add that some existing treatment effectiveness data could benefit from better integration with evolving data and theories regarding nature and etiology of stuttering. So also here, this author tells us that, sorry, let's come back here. So when we see this, this kind of, I'm sorry, because this was, okay. So when we see the lot of evidence-based treatments that are being developed, we see here, for example, Mark Power that states that I believe that my task as a clinician is to implement the most effective treatment for the people who stutter that come through my door. I rely on research to point the way to effective treatment today. I feel that I owe my clients the best service possible. And I believe that this means exposing them to treatments that have been researched in well-designed outcome or efficacy studies. And then we have Yarus and Kezal, and they say, like Power, we value published research data on the treatment of stuttering. We also value data that we collect during our own treatment with people who stutter. We believe that it is far from being irrelevant simply because it is not published. Indeed, it is highly relevant to the individuals we are treating, and it provides perhaps the most important measures for guiding the direction of treatment. Furthermore, we do not think it's appropriate to avoid well-established treatment programs that have been helpful for countless people who stutter simply because data are not yet published. From the perspective of an evidence-based treatment philosophy, one could question how certain treatment procedures could become well-established without having the benefit of research evidence that demonstrates their effectiveness. One might wonder as well how it can be known that such programs have been helpful for countless people without systematic evidence to support that assertion. So here we see the very best 2 points of view of evidence-based practice. On one hand, we have to go and to search from evidence that is published on papers, but on the other hand, we have to monitor our assessment and intervention sessions so that we can gather all of this information and we can give the best possible response. So we could keep going on these reflections because there are so many interesting things to discuss regarding this topic and its implication in our ultimate goal of intervention, that is the communicative effectiveness, the achievement, the well-being of the person who stutters, and the empowerment of family and friends and environment. So if the evidence-based practices start with targeting and focusing questions, maybe we should ask ourselves as a speech and language therapist, do I know the state of the art regarding the complexity basis of stuttering? Do I know the state of the art regarding assessment and intervention with the person who stutters? Do I know the state of the art regarding assessment and intervention with the family, the friends, the environment, all of these that are important for the person who stutters? And so much more questions can we do to ourselves in our day-to-day practice. This is, of course, an ongoing challenge as research is bringing on so much new information, but we have to keep the pace so that we can honor our profession and we can honor each person that trusted us in the moment we were chosen to be their speech and language therapist. Thank you so much for being here with us.
Thank you so much, Elsa. It was an amazing lecture. And I personally have 2 questions for you. And when colleagues are thinking also to do some questions. One of them, it's about education, in fact, of speech therapists who work on stuttering. I remember when I was a student and it was so hard to understand, for instance, how stuttering modification techniques were made. I didn't have the chance to have a teacher who explore with me, for instance, about these techniques or desensitization techniques, or I remember I was reading about speech techniques and you imagine something, but you don't know exactly how to do it. And something that I saw in a later stage, it was some people who run research about the specific techniques. When I explore with them, I'm amazed because they don't really know how to do it. And I'm serious.
Yeah.
And why I'm telling this? Because we have a lot of research about fluency shaping programs and about programs in general. And unfortunately, not that much about integrate approaches or comprehensive approaches that also use stuttering modification techniques and counseling. That's why in our course, we insist so much about how to use stuttering modification and put videos of people doing the techniques, and we do the lives exploring the techniques, because I know how hard it was for me. And only I had the chance to work with Professor Barry Guitar, and he taught me, and it was a turning point for me in therapy, because I really understood the power of this kind of techniques. So my question for you is, programs and process, and how evidence-based is on, because we know stuttering modification have a lack of evidence, unfortunately. And sometimes I think some SLPs feel less confident to use it. So what are your thoughts on this?
I think that you brought up two very important points. The first one for me is the education regarding assessment and intervention in stuttering. So not only talking about higher education of speech and language therapists and the way that they are taught regarding the process, the paths that we have to take into account when we assess and intervene with the person who stutters, and always the family, the environment, all of this that we know. The second point for me is the ongoing training. We know that we as speech and language therapists, we must always invest on our ongoing training, because research is developing in such a fast pace that we have to be on the new things that are happening. The other thing that you talked about, stuttering modification. And first of all, when we think about stuttering modification, I think that we have to think about the different steps of stuttering modification. And here, for example, you have the sensitization. And when you have the sensitization, and if you read Ratner's article, you will see that Ratner talks about that. And what she says is, okay, maybe we do not have an explicit research about that, but we have implicit research about that, because if we see, we have disorders where we can make some analogy with stuttering, and we see that in those disorders, for example, the sensitization is main and it plays a main role. So I don't think that we can say that we don't have research. I think that we have research, but we have to look for this research, and this is not just maybe a direct relation where we see that here stuttering modification and the research. No, we have to go deeper, and we have to understand this deeper. It's just like we are talking about the sensitization, we are talking about talking about stuttering modification, we are talking about counseling, for example, maybe you don't find explicit research concerning person-based or family-centered practices or person-centered practices concerning stuttering. But if you will see, you have a lot of this information regarding the person intervention. So I think that we have to demystify this kind of thinking, of this research thinking, because we have evidence. And beside that, let's think about what Jaros wrote. And this is also evidence-based practice. What does our clinical practice shows us? That's a very important post. Clinical evidence-based practice is not only speech, is not only scientific research, it is also practice. There is only one point. I know that we don't have time, but I want to say this. The thing that you were also saying about the techniques and the way the students or the speech language therapists learn, I think that sometimes, and I feel this in my students, we want to go directly to the point of the blocks, the repetitions, and the prolongations. And we forget that or we want to go directly to avoidance or escape behaviors, but we forget that or the basis of these are related with emotions and feelings and attitudes. So what's the point of going directly to the thing that is not the base of the situation? We will go there, and fluency shaping does not take into account these emotions that are the basis of these stuttering challenges.
Totally. Thank you so much.
Thank you.
It was great to hear you.
Thank you.
We have to move, and let me share that all the lectures are not just colleagues, not just from my team, but they are close friends, and all of them are gifted speech therapists. So that's why when I introduce them, it's like just this is Anna, this is Elsa, this is Katia, because it's how I see them, but they are so much more than that. So Elsa, thank you. Bye-bye. And now I will introduce Anna and Katia, and I challenge them to bring the topic about stuttering comorbidities and why and how does it impact the therapeutical process. Because something that always concerns me is I'm really concerned when you use only one approach for all the children. for me, that's something, it scares me. I will share this. It scares me because I know it's impossible. And I have the theory, no one will be left behind. So we need to learn about everything to cover the needs of everyone. Yeah, I'm that utopic. And that's why I invite Katia and Anna, because something that we know, it's sometimes a neurodevelopmental disorder. In the future, it can turn in a mental health disorder. So we have to keep this in mind when we treat kids, and we have to keep this in mind when we treat adults. So my thought was, let's combine this in just one lecture. So I want to introduce Katia and Anna, two of the greatest therapists that I know. And please, the stage is yours.
Good morning. Good morning, everyone. Thank you for this introduction, Gonçalo. I hope that we are up to the expectations. So I will share my screen. Can you see the presentation?
Yes.
Yes. Okay. So Anna and I will talk about stuttering and comorbidities and reflect about why and how can it impact the therapeutic process. So let's firstly understand what it means, comorbidity. According to the American Psychiatry Association, who wrote the famous DCM, and its latest version, the DCM-5 Test Revised, comorbidity refers to mental disorders and medical conditions that can probably co-occur with the disorder about which we are talking about. So the use of this term comorbidity is relatively recent. The first descriptions appeared in the 80s, and the terms comorbidity and co-occurrence have gained popularity with the increasing recognition that many neurodevelopmental disorders rarely present in isolation. So what comorbidities are these? We are talking about mental disorders that are considered an umbrella term that includes the neurodevelopmental disorders such as autism spectrum disorder, ADHD, tic disorders, specific learning disorders, and communication disorders, where we will find stuttering, developmental stuttering, or childhood onset fluency disorder, as it's called in the DSM. And on the other hand, we have the mental health or psychiatric disorder, such as bipolar disorder, depressive disorder, and anxiety disorders, such as generalized anxiety disorder, obsessive compulsive disorder. The neurodevelopmental disorders are a group of conditions with the onset in the developmental periods that are characterized by differences in brain processes. And these differences will produce impairments of personal, social, academical, or occupational functioning. And today, we know that neurodevelopmental disorders co-occur with one another. This is more the rule than the exception, and stuttering is part of this group. Regarding mental health or psychiatric disorder, this can divide into internalizing and externalized disorders. And we know that 50% of the cases are established by the age 14 and 75 by age 24. And even that we know that the impact that they can have on the person's quality of life, studies report that 70% of children and adolescents who experience mental health disorders have not had appropriate intervention at a sufficiently early age. I really like the title of this article. If we are talking about comorbidity, co-occurrence, or a continuum, and this is what we will discuss now. Because some authors propose the model of a neurodevelopmental continuum, in which neurodevelopmental disorders are seen as representing a diverse range of outcomes that follow from a brain with a deviant development. So childhood neurodevelopmental disorders and adult psychiatric disorders could be better conceptualized as lying on an etiological and neurodevelopmental continuum rather than being defined as separated entities. And this model is based on the emerging evidence for shared genetic and environmental risk factors and predicts that there are likely overlapping pathogenic mechanisms between these two. So let's now think, why does it impact the therapeutic process with people who stutter? And for that, we will talk about numbers. And what we know is, for instance, on a study of 2001, we found that 44% of the included 467 children who stutter had also a phonological or language disorder in addition to stuttering. On the same study, we have, from the 262 children who did not have other confirmed condition behind stuttering, 42 were suspected as having other disorders. And in another study, we have 62% of a lot of children who stutter that exhibit also other speech and language and non-speech and language disorders beyond stuttering. On other studies, this one from 2018, we found that 62% of children who stutter reported at least one disabling developmental condition, compared to only 15% of children who do not stutter. On the same article, we found that 29% of these children had at least two disabling conditions from developmental conditions. And in the more recent article of 2020, we see that 60% of children who stutter had at least one comorbid condition. And looking at what are these comorbidities, focusing on neurodevelopmental disorders, I want you to notice that while we have a percentage of 8% of children who do not stutter with ADHD, we have a prevalence of 25.56 in the group of children who stutter. And regarding ASD, autism spectrum disorder, we have a percentage of 1.45% in the group of children who do not stutter, and a prevalence of 10% in the group of children who stutter. When we look at other studies, we can see the same pattern. For instance, regarding ADHD, we have 25% in the group of children who stuttering and 8% on the control group. And regarding, for instance, learning disability, we have 32% on the group of children who stutter and only 7% on the group on the control group. So here we understand that these numbers are really, really higher in the group of children who stutter. And on this article, more than focusing on the numbers about concomitant communication disorders, I want you to focus on the 42% of suspected disorders. And why do I want you to focus on this? Because we know that on investigation, and especially when we are talking about professionals that are experts in autism, ADHD, sometimes they are looking at stuttering, but not from an expert point of view, or with not so much experience as they have with ADHD and stuttering and other neurodevelopmental disorders. So what we see is that is a lack of homogeneity between the technical language that is used to describe, for instance, stuttering disfluencies, stuttering behaviors, and this makes it difficult to draw conclusions regarding the fluency profile of people with comorbidities. And the problem is a lot of problems here, but one of the problems is that when we have a child with many needs, in these complex cases, children usually have many needs, fluency is usually placed on low in the priority list in the intervention process. So these numbers may be even higher. And let's look what is happening in the adult age. And here is when we get back to the connection to understand why we can talk about a continuum. And starting from neurodevelopmental to mental health, what we can see is that the results of this study right here shows us that due to cognitive deficits, especially on executive functioning, children with neurodevelopmental disorders will experience great maladaptive emotion regulation, which predicts both internalizing and externalizing problems, such as anxiety, depression, and aggressive behavior. And on this study, with 260 children between 7 and 13 years old, 55 met criteria for at least one neurodevelopmental disorder. And this was a group that visited a psychiatry clinic. And from this group, for the children that had neurodevelopmental disorders, we had 58% that had one or more psychiatric comorbid disorders. However, we can also go from mental health disorders to neurodevelopmental disorders. And this is, and why is important to talk about this? Because even that we know that is very common among children with neurodevelopmental disorders, and in general, in neurodevelopmental disorders, we know that these disorders tend to persist to the adult age, but we are not seeing a lot of research about adults with neurodevelopmental disorders. And this article can explain us a little bit why is this happening. So this study highlights that neurodevelopmental disorders are not being the first diagnosis that adult psychiatrists have been looking for. Instead, patients have been diagnosed with affective disorders, anxiety, personality disorders. And these may increase the risk that neurodevelopmental disorders are not being assessed at all at the adult age. So, and in this study with 172 people between 18 and 25 years old, these were first attenders on an adult outpatient psychiatry that were invited to take part regardless of cause of concern. And the participants were assessed concerning psychiatric problems, neurodevelopmental disorders, cognitive functioning, and they used psychiatric interviews, self-rating scales, and neuropsychological tests. And what they found was that 53% met full criteria to ADHD diagnosis. And from this group, 62% were not diagnosed. They also found 20% of adults died with autism spectrum disorder, and 79 were not diagnosed. And in this group, we had 53, a half, that had ASD and ADHD. In this group, they also found that 3 met criteria for Tourette syndrome, and 2 of them had also ADHD and ASD. And among this group, we had a high rate of overlap between psychiatric disorders and neurodevelopmental disorders. For instance, people with ADHD and personality disorders. So when we look at numbers, again, as Gonçalo showed, when we look at numbers on stuttering, other neurodevelopmental disorders, and mental health, we see that the percentage, the prevalence of people with social anxiety disorder is much higher on the group of adults with stuttering when compared to the control group. And this we can see in different articles, but we also see in articles that we have a lot of adults that can meet criteria, for instance, for ADHD, but they are not diagnosed. We also have here other articles that shows us that on a group, for instance, this article, in a group for 526 adults with stutter, we have 42% of adults with anxiety disorder, 21 with ADHD, and 12% with autism. And to finish these numbers, I want you to take attention to this, because when compared with match control, we know that people who stutter have high levels of depressive symptomatology and significantly higher likelihood of suicidal ideation. And here we find more suicidal ideation in males than in females. So, to finish and to give the words to Anna, why does it impact our therapeutic process with people who stutter? The numbers don't lie, and comorbidity is more the rule than the exception. So we must look for information to knowledge that give us the knowledge to be able to identify signs of these comorbidities. And this longitudinal view helps us to understand the consequences of ignoring these comorbidities. So we cannot do this. And we need to understand the why so we can more consciously and effectively adapt the how.
Hello, everyone. Good morning. I hope you are doing well. Sorry not introduce myself in the beginning, but I'm going to talk now. So now that Katia talked about the why should we talk about this topic, why is it important, and I was reading some of your messages in the chat, I'm going to talk about how does it impact our work with these people with comorbidities. So I will ask you something. Because there are so many therapists here, and your questions may be regarding the therapy and therapy plans and therapy goals. Share your comments, because I don't have a lot of time to talk about this. So share your comment, your thoughts, and maybe after this, we can talk a little bit about something that you think is important. So to talk about this, and because numbers don't lie and they are so expressive, there are so many people, children and adults with comorbidities, I will talk about some topics that I think that are really important so we can do our best job with these people and families and really make the difference. So I will be talking about assessment, about the knowledge that is necessary to address all this, teamwork. You talk about psychologists here, so let's talk about that. About therapeutic priorities, about expectations, counseling skills, and something that I think Katia and I really think that is very important, that is flexibility as therapists and critical thinking. So, talking about assessment, in this specific profile, in this type of cases, we think that it's really, really important to have in mind a multidisciplinary assessment from the start. What is different, or maybe different from other cases, is that sometimes in the middle of the process or at the end of our therapy process, we provide referral, or we start talking with other professionals. But in this case, it's very, very important that we do it from the start. Why? Why do we need psychologists? Why do we need other areas such as motricity, sensorial integration, psychiatry, pediatricians? Why? Because if we don't do it in the assessment period, we will not understand the case. So we will not address all the needs that the case is showing us, because we will not see it. Okay, so from the start, multidisciplinary assessment. To do that, yeah, Katia, you were, okay, thank you. So to do this, we need to develop a transdisciplinary knowledge. So what is this? This is not just a knowledge that is from each of these areas in particular. This is a knowledge that is about how they relate, how they connect, and how they help us understand what we are seeing happening in the person that we are working with and their families. So if we understand how psychology and speech therapy and other areas interact, and how parameters that they assess and we assess come together in one behavior, then we will improve our diagnosis. We will better understand the impact of the disorder and the comorbidities. And we will identify therapeutic needs in an easier way. So this is important because, as Elsa was talking to, assessment should be individualized, so should be our treatment plans. And the only way of doing this, of creating individualized treatment plans, is to have all this knowledge and all these discussions going on. How do we develop the necessary knowledge to do this? Well, we keep learning, we update, we do this investment of keep learning every time, every week, every month, not just with our clients, but with evidence and other professionals. So if you have the opportunity of having these joint discussions and these team discussions, as for example we do, you will see the difference. You will notice in yourself the difference when you are talking about these cases. And of course, if you have mentoring, even better. Okay, so let's talk about therapeutic priorities, okay? And what should we do first? Well, first of all, we know that fluency is important. And most of that, and more than that, many people that come to us, they tell us that the important thing is that it stops stuttering or stuttering disappear. But we also know that in many cases that will not be possible, not just for adults, but for children too. And with comorbidities, specifically, we are talking about, for example, children that have a high risk of developing a chronic stuttering, so stuttering persisting and not disappearing, okay? So if we have all this in mind and we are doing our best job to promote mental health, to promote full participation, to promote well-being in communication, because why do we need fluency for? We need fluency to connect. We need fluency to relate. We need fluency to communicate and feel good doing it. So if we consider all this, maybe fluency is not the only goal that matters. Maybe it's not the priority, okay? So I'm going to talk about how to think about this because I have your question here from the chat. But before that, so if we are talking about fluency, of course that reducing stuttering frequency is important. Reducing stuttering moments duration is important. But what about communicative freedom? What about reducing avoidance? What about promoting and developing communication skills? What about self-efficacy in communication? Isn't it so important? Yeah, okay. So now let's talk about expectations for therapy. We talked about that, but what should we know about these specific cases with comorbidities? Is that it's proved that it may take more time of therapy. So the interventions can be longer and it may be more difficult to maintain therapy gains. So we will have relapses more than usual. We will have some ups and downs, and we have to deal with it, not just as therapists, but help the person and the families deal with this. We will have a nonlinear therapeutic process. Let me be clear, all therapeutic processes are nonlinear. What I want to say with this is that maybe in these cases, we will go back and forth more often, okay? And that is the way, it's okay. we will have more interferences in some of the parameters that we are working with. Let me give you an example. I was working with an adult who stuttered, and she started a new medication. So when she started that new medication, she started with this eye movement of blinking and really closing a lot the eyes. So of course we had to address that in therapy because it was escape behavior. Okay, but that came from other thing that was going on with that person. Yeah, and that is normal. We may have more emotional, psychological, and social impact of stuttering. And we may have more impact in the family too. And this is very important to have in mind when we are conducting our sessions and the phases of therapy. So I really like the graphic that is in this graphic, because it's from a study with adults who stutter. And it was conducted with adults who stutter and didn't have any mental health disorder and have mental disorder. So what the conclusions were this, or one of the conclusions were this, that after the treatment, the adults who had something else going on in mental disorder, other disorder, they experienced relapse much more than other adults who didn't have any kind of disorder, additional disorder going on. So this is a reality, and it's okay. And so it may be longer the therapy because of that too. Okay, so this is a big need in these cases, and I'm talking about teamwork because, as Elsa said too, some of the decisions the important decisions in these cases are joint group team decisions. So we need everyone to understand what is important, and what is important is what is having most impact on participation, on functioning in daily life. So I don't know if it is stuttering frequency, if that is phonological skills, or other parameter that we know that is important for the case, because we have to ask all involved what is going on and how can we help. And of course, we may have important information for this, but it's not our decision, it's a joint decision. So I'm talking about the person who stutters, professionals, family, and teachers when we have teachers involved. Now, counseling skills. Why did we choose this topic? Because many times we have such emotional load and we have executive profiles that have reduced cognitive flexibility, that have anxiety, they have so many things going on, and maybe these people are people that tend to be the world as much more scary and with scary social situations. So as therapists, when we have, and we always have these components, right? Emotional, cognitive, and behavioral component in stuttering. But in these cases, this can be even more heavy. So as therapists, we shouldn't be working on this in an intuitive way. We really should know what we are doing and use specific techniques and specific procedures that we know that are validated in some way. Okay, so here are some approaches that we combine with our technical functional work that could help us to have a more holistic and proper approach to these cases. So when we are working with people who stutter and we are providing counseling, we are helping the person to make changes in cognitive and behavioral changes that allow successful adaptation to life situations and contexts. We are also helping the person to develop autonomy, critical thinking, and self-aware to maintain, for example, therapeutic gains. And when we are providing counseling to families, we are giving families the information and the experiences that they need to make decisions together, to support the person who stutters, to have a positive communication going on, and to help the person and us and everyone involved to eliminate communicative barriers from the context, in community, okay? And now, talking about us therapists and how we think and how we work, how we prepare to approach and help these families, we really think that it's very important to remain flexible, to remain critical. Why? Let me ask you a question, this question. Do we believe that there is a single model, approach, or program to work with these cases or any case of stuttering successfully? We do not. Why? Because they are so different, because they have so different needs and priorities. So, and we have so many resources. So let us see the next slide. Yeah, so we have so many resources, okay? Fluency shaping, stuttering modification, mini kits, LeadCom program. Well, you know, you can choose integrated approach. There are so many. So give us so many resources. And something that is very, very important is this. Okay, so from evidence, we know that these programs or approaches, even CBT, even counseling, the other areas that are not here, they tend to work, okay? We have results on the efficacy of most programs, and what evidence tells us is that they work, they can help people. But another important part of this is that they can't help everyone. Even the participants of the studies, they can't help everyone. So it's a high percentage of people that are satisfied and have results, but not all participants, so not all people. So why should we in our clinics, in our therapeutic realities, just use one when we have so many, and we know that one not suits all? Yeah, so that is a deep belief of Katia and I, Gonçalo, and our team. Okay, and to finish, we have also other models to think health services that are not just therapy, that also bring a lot of flexibility and is the same rationale here, okay? To end this, I'm sorry, Gonçalo, I'm seeing you, and I don't know if I'm going late or not, but I'm finishing. So Katia, the next slide, please. Yeah, Katia and I would like to finish by leaving you with a take-home message that is this message from Stuttering Foundation that says that we SLPs are not technicians, we are facilitators of change. And to facilitate change, we need to understand two things. One is that we need to put our clients' needs and priorities first, okay? And second is that we need to understand what change takes in each case and for each person. So thank you very much, and it was a pleasure.
Thank you so much, Anna and Katia. It's always great to hear you all. And the slide that I put some time pressure on you, it was a really important slide because I really believe we can include all of those approaches on our intervention and those, I don't know, philosophies or views or perspectives. So we have here some questions, and I will try to combine in three, okay? One I will answer just to and one for Katia and another for Anna. One was of a comment if stuttering can be considered or understood as a syndrome, because our colleague, she read something like that stuttering may be only one form of manifestation of a bigger syndrome related to motor disorders. I don't think stuttering should be considered a syndrome, but I understand what you're saying. In fact, we didn't discuss etiology in this specific conference, but we know that a lot of etiology of stuttering is related with the brain, and it's related with the basal ganglia loop. And we know a lot of movement disorders are related with basal ganglia loop. A lot of neurologists, they say that stuttering should be considered a movement disorder because he shares a lot of characteristics with other disorders. In fact, probably the most similar one is Tourette syndrome. So I understand your comment. It was a big discussion, but I think you understand why the similarities. So I have a question to Katya, then I will put it together. It was a very important question for our colleague Binta. And she was saying, what about if a child have stuttering and phonological disorder when we have the coexisting of both, that we know it's a very typical case and very typical comorbidity. And we also know, because this is really important, a lot of colleagues, when they have both, they start to work phonology and stuttering gets worse. So we'll like to Katya address that. And we have also other colleague who's talking about adolescents, and it's a group who have cerebral palsy and stuttering. If you think that fluency shaping, it's enough, traditional approach with fluency shaping, because we have some involuntary movements, if other approaches can be hard to do.
Yeah, so regarding the phonological language disorders, what we know is that firstly, we need to understand the impact of those two. And I always talk about this with parents. We can separate like totally these two, language, these three, four, what we want to talk about, because language, speech, fluency, they are always related, and it doesn't make sense to separate them. And for a child that stutters and have a language disorder, phonological disorder, we need to understand the impact of those and how they relate to each other. And for instance, sometimes we have children that feel more impact on stuttering behavior. Some of them feel greater impact from the fact that they are not understood by others. So we need to look at that too, to set priorities, to set our goals. But what we usually do is work by an approach that is called cycles approach, that is known for phonological disorders. And now we have a book that is very famous on our clinic. We are all of us are always talking about that. That is a new book that talks, I don't remember the name. Do you have it there, Gonçalo? The new book.
The new book, yeah, continue. I will look for it.
Okay. But it's a very good book, and I really loved a part that talk about the intervention with cases with comorbidities, and this can be applied to phonological, language, cerebral palsy, and other needs, because it's related, the cycle approach, not only for phonology, yes, that one, not only for phonology difficulties, but to all the others. Because what we can do is to, set goals for all of them, and then work by cycles. Like, let's define that we will work now more here, more that, and we will change like in 2 weeks or something. But always with the base that, and that's the most important part for me. For instance, I never start working on speech sounds in advance. I always do a more cognition work to let the child understand what is speech, where are the stuttering moments, to give names to stuttering, always read analogies and everything that makes sense for them, but to let them understand what we are doing and to decrease their reactivity to stuttering. Then we start working on these different needs. And this is something that we can use to work with these children with complex needs. And for me, it makes a lot of sense. And just one thing, sorry, about the question about fluency shaping. I think that I will never say that we can only use fluency shaping or this or that for any case. So I will not say this for this group of children and adolescents. I think that you need to understand, and even though we have these people with complex needs, they all have difficulties, but they also have strengths, and we need to understand their profile and to use this on our intervention.
Thank you so much, Anna. I have a question that will take 1 minute to answer from your side.
From your last, okay, tell me.
So about psychology, when do you think to do a referral to psychology?
Well, I always do a referral when I see that maybe the person or appears to have a low cognitive flexibility. So it's hard to change, it's hard to modify the way I'm thinking, it's hard to integrate new information into new information to the way I'm functioning. And also when the person tells me about some very intense feelings, very is not being afraid of something, is feeling panic, is being under so much stress that I can't function. So I need help from this particular professional to assess this and have an opinion about what's going on.
Thank you so much. Thank you so much, you both. It was a great lecture. I'm quite sure our colleagues enjoyed to hear you and all your experience. And Katya, please, can you share on chat some literature about approach to phonology? I think some people will enjoy to know more about it and to introduce in their therapy. Thank you so much.
I will. Thank you. Thank you for hearing us.
Bye-bye. And now let's proceed. I have the pleasure to introduce Farah Al-Kassi. I don't know if Farah is there. Yes, she is. Hi, Farah. How are you?
Good. Thank you for having me. How are you?
Oh, thank you. Thank you. It's always a pleasure to have you. And Farah will talk about raising awareness in the UAE. And let me share that when I met Farah, for me, it was, I learned a lot. That's the truth. And I was so amazed about the work that you've been doing, not just in UAE, but in the region, to increase awareness and the way you do it. And because I know how important it is to fight stigma, how important it is to educate people, because like we explore in other lectures, how stuttering affects a person, it's very individual and it's also culture related. So it's different being a person who stutters in UAE of being in Portugal or in Spain. So this is something that we should work society and community, and you're very brave when you're doing that. The other thing is I use a lot of your materials in my therapy because like Anna was exploring, people who stutter are not just a mouth who stutters. This is a sentence of my dear friend Annalise Bonnen, who will join us later. But there are a lot of characteristics, a lot of experiences, and something that I work a lot, it's stuttering with a smile. So this is a goal in therapy. Are we able to go to the street, to a coffee place and stutter with a smile? And I always share some materials of Stutter UAE about that so they can get inspired. So again, thank you for that. And thank you for having you here.
Thank you very much, Gonçalo. And it's truly an honor to be here. And I'm humbled that you're using whether it's my content or Stutter UAE's content in therapy. Everything that I'm gonna say today really complements everyone that have already spoken. As wonderful of the work that a person who stutter can do in the therapy room, it's important that they take that strength with them once they leave. And more times than not, it's easier said than done. As a person who stutters myself, I went through my own journey of discovery of who am I despite my stutter, rather than who would I be if I didn't stutter. And which led me to accepting that I can stutter with a smile. And what was interesting is the very fact that I've accepted the fact that I do stutter, I've started to notice my feelings, my emotions behind the stutter to minimize. And as a result, my stutter isn't as overshadowing me as it once did. And that's ultimately what we try to do through Stutter UAE, which is the initiative that I started back in 2013 to support people who stutter, to create a platform where they feel it's safe for them to speak how they feel and be how they are, regardless whether they have a severe stutter or a mild stutter. And throughout this journey, and I've been very, very blessed to encounter so many individuals who stutter from all around the world that shared with me that through just accepting the fact that they stutter and not trying to really change that, just to pause and go like, yes, I stutter and it's okay. They became more open to accepting therapy, accepting themselves, which smoothened their entire journey in general. Because I personally believe that we should all be proud of all parts of ourselves. And stuttering, as we know, is really an iceberg. And if we do not address what's happening at the core, at the bottom of the iceberg, a lot of the work that we do at this surface might not completely flourish. And throughout this journey with Stutter UAE, which really just started because I wanted myself to meet other people who stutter. I felt alone in my stutter. And I wanted to see who else in the UAE stutters. That curiosity has led me to meet people in the UAE who stutter, partner with wonderful members like Gonçalo and his team, and all around the world who share that vision or share that reality of stuttering is okay. There are ways to, for lack of a better word right now, to manage it. And we can still live with a stutter, because I've noticed a lot of people are ashamed of how they speak. And they're comfortable opening up about it on a one-on-one basis, whether with myself, with their therapist, but they're not so comfortable acknowledging it to their family, their friends, in social settings. My personal experience was I stood up in front of all my classmates in university and I said, Salam alaikum, my name is Farah, and I stutter. Please bear with me. Until this day, that sentence causes some uncomfortable feelings, but I knew the only way through is through. And I've seen this journey of acceptance flourish. We've had collaborations from the UAE, the GCC countries, all around the world. There was a short film documentary made called Just Another Accent. And that's exactly how we view our stutter. It's just another accent. And simply by changing our perspective of our stutter, we're able to overcome that first step of fear and do the changes that we need to do as individuals that will help us achieve our personal goals. And like one of the biggest highlights, and to Gonçalo's point, stigma is very strong in the region. And it goes back to the fear of what society will think of me as an individual, and at a more higher level, as a parent, what would the people think of me as a parent if my child stutters? So it's a very entangled dynamic, I would say. But with the efforts that we've put in Stutter UAE and the annual event that we host, the Stuttering Awareness Day, really speaks volumes. And I'll just, for the sake of time, I'll just conclude with this. Every person I meet who stutters, I make sure to reinforce that concept of we are each ambassadors of our stutter. The dialogue needs to start with us. We need to lead that change because not everyone is aware of stuttering. We are. And that perspective, and I'm so humbled that in 2018, because of the efforts put in Stutter UAE, I've been awarded the highest civilian award in the Emirate of Abu Dhabi, in the UAE, by our President Sheikh Mohammed bin Zayed Al Nahyan, through the Abu Dhabi Award. And that has reignited the belief for people who stutter, for their families, for the society as a whole, that our voice matters, our presence and active participation in the society is critical for the success and the flourishment of ourselves and the communities that we're in. Thank you very much.
Thank you so much, Farah. I know you have a lot more to share, and I'm here putting some pressure. But you said so many important things, and I want to catch a few and
Sure.
explore with you. So, and also with our colleagues, that community is so important. It's really important. I always establish as a goal when I'm doing therapy that someone should found his community, should go to a meeting with other people who stutter as a group, and particularly this event that you organize. It's so important. And you said something that there's still a lot of stigma in the region, and it's true. And something that is impressing me a lot is in families. And I know it's because of a lack of knowledge. I know it's because people don't know more. And I really think we as a professional group, my colleagues, speech therapists, should be involved more. And I really advise everyone to join on this event. I think you can go to Stutter UAE Instagram and see all the information about the event and how you can participate. You can also, we'll have our virtual reality prototype there, so you can try it. So you'll see Elsa there with our prototype. So it's also an experience that you can have. And I believe if you have people in therapy in UAE, people who stutter, kids, adults, whatever, if you take them to these events, for them, it will be a life changer moment. Because I know how powerful these events are. And on my side, I want to thank you, Farah, for everything you do. I see here a lot of comments that people are proud of you and how important it is what you do. And yeah, and that's true. And you keep going, keep inspiring us. For me, it's always a pleasure, and I'm so happy to partner with you. And to be able to take the word out in the region, it's really, really great. So thank you so much.
Thank you very much once again.
So I invite everyone to take a look on Stutter UAE page and participate and get involved, because we need everyone to the word out. Thank you so much, Farah.
Thank you.
Okay, so we are running to our last lecture, and Farah helped us so much to be on time. I want to introduce my dear friend and colleague, Annalise Bonan. Annalise is the president of the Brazilian Fluency Institute. She's PhD. And more than that, she's a partner for many, many years that we've been working hard educating people about stuttering. She also participates in our stuttering course. That it's great. And today she will talk about differential diagnosis between stuttering and cluttering. That is something that people have a lot of doubts on that. Hi, Annalise.
Hi, good morning to everybody. Here in Brazil, in the very south of Brazil, it's 11 degrees Celsius. And sun is just rising, you know, it's 6 o'clock in the morning. So I'm so glad to be here with all of you. Thank you so much, Gonçalo, for the invitation. And Farah, thank you so much, because you're doing such a great work. And I just loved your speech, you know, a few minutes ago. It's just wonderful. Stutter with a smile is a great motto for all of us, I think.
So I think you
Are
can.
we ready to begin?
Yeah, we are ready to begin. And thank you so much. I know it's so early in Brazil. Thank you so much for joining us.
This is it's just fun. I'm going to share my screen with you then. So let's see if it works. It's always, can you see it?
Yes. Perfect.
Oh, good. Let me get this out of here. All right. So we talked about a lot of things today, and usually when we talk about stuttering, we think about exclusively stuttering, but we know that we have a lot of other fluency disorders. The book Gonçalo just showed us briefly from Zibrovsky, we talk about other fluency disorders. And it's important for us to understand that lots of times cluttering and stuttering are mixed or confused in terms of diagnosis. And there are certain important differences between both pathologies, and we have to understand them a little bit, okay? So I know I have, let's begin because the time is running. Okay, so first of all, we have to understand how stuttering is being described lately, because with the new ICD-11, all the description about stuttering has changed. So there are descriptions, there are no definitions, because we still do not know all the causes of stuttering. So the ICD-11 will describe stuttering for us, which is very good. Okay, so what are the descriptions that we have to guide us, not only as a speech pathologist, but, you know, as people who stutter, to understand that, you know, stuttering is a word that is very big, you know, it's kind of discussed, the exact meaning, etc. right now. So let's do the most used and accepted descriptions are those from the World Health Organization and the American Psychiatric Association. And why is that? Because these are universal. The ICD has the epidemiological factor So when you say like stutter F98.5, it means that the World Health Organization will know how many pediatricians are plotting in the site of the World Health Organization, how many people stutter, for instance. So this is important. And because these are global organizations, so they will serve as reference. It's easier, okay? So in the ICD-10, that is still being used in most countries because of the pandemic. It was supposed to come in now in 2022, but most countries still are using the ICD-10 because the ICD-11 was not translated completely to everybody. So in this ICD-10, the code is F98.5, and there stuttering is described as a speech that is characterized by repetitions, prolongations, sounds of words and syllables, things that you know that we have already heard. Okay, so this description mentions the characteristics of a speech that is heard for a person who stutters. Okay, so this description never mentions causes. So we're not going to say stuttering has emotional causes or whatever. It doesn't mention causes, right? It much less that it has emotional implications. And because this description will be officially surpassed in 22, let's see what happens with the ICD-11. And it's very, very nice because I like it very well, because for the first time, the World Health Organization says totally that stuttering is a speech and language problem, and it places in the chapter of the neurodevelopmental disorders, but the description talks about speech and language pathologists, as we are. So this is a description taken directly from the page of the ICD, and they are describing stuttering as a developmental speech fluency disorder. And if you plug into this site, you will never find the word stuttering. They don't say stuttering anymore. Now we're talking about developmental speech fluency disorder. And the description is very interesting because it's built on the new knowledge that the neuroscience has brought to this area of study, especially dealing with all the, the publications from Dr. Shang and others that are studying children neurologically who stutter. And this description follows, as you saw here, there is a main axis, and the number will be 6A01.1, whereas they have in the axis 06 3 distinct areas: mental disorders, behavioral disorders, and neurodevelopmental disorders. And we have stuttering, as we used to call it, under the neurodevelopmental disorders. Okay, so classifies stuttering as a speech fluency disorder. And I wanted to emphasize the expression fluency of speech, because fluency is one of the parameters of language, and speech is the oral expression of language, which means it's a language disorders, and that's why we are here talking about this. And to have a good oral language, of course, we need to speak fluently too. Not necessarily, but fluency is, we can stutter with a smile, but it's within the parameters of this language system. So, and also this description places stuttering in the field of speech therapy, which has language as its main disorders in object of study, okay? And then it says there, developmental disorder of speech fluency is characterized by persistent, frequent, or pervasive disruptions of the flow of the speech that will arise during the developmental period. And this is important because this is while the child is growing up, between 0 and 3 or 3.5, 4 years old. That's why it's called neurodevelopmental period, all right, and are outside of the range of normal expected range for age and level of intellectual function, and result in reduced intelligibility, and significantly affects communication. It may involve repetitions of sounds, syllables or words, prolongations, word breaks, blocking, excessive use of interjections, and abrupt and rapid breaks in speech. Again, note that in this description does not have the word stutter. They classify this as a developmental disorder of speech fluency. And this is important. We gradually have to, maybe, we have to agree within our community how we're going to, have another name for it. So we have two international organizations that call about speech and fluency disorder, and they are saying the word stuttering is not being used. So we have to think about that. And the World Health Organization also produces the International Classification of Functioning, Disability, and Health. And in this case, it's important because the ICF was created to describe health-related status and conditions, but it's not a classification. It does not put the person who stutters within a code. We will generate different codes according to the things that somebody here already talked about that in terms of how it works in terms of body functions and structures, activities, and participations, and the fluency and rhythm of speech functions within the ICF. It says it's functions of production of flow with speech time, inclusions, speech fluency, rhythm, speed and melody functions, prosody and intonation, internet impairments such as stuttering disorder, bradycardia, and tachycardia. Here you see already that we have different fluency disorders that are cited here. So in short, we have the ICD-11 and the DSM-5 are biomedical models, and stuttering described through the observable characteristics, which is different in terms of the ICFs because it's a model, it's a biopsychosocial model, and there's a reference about a person's functionality within the context where the person is involved in. So the two are centered on the pathology, and the third is a person-centered. So these are different ways of looking at the person who stuttered and to the pathology, but they are not exclusive, they are complementary. Okay, so we have to know all of them. So Katya and Anna were talking, there's no one single way of doing this, and we have to understand. On the other hand, as a community, especially a community of speech and language pathologists that will work with you that stutter and need help, we have to understand all of these things. Okay, so what are the observable characteristics that we see? We know that, I'm going to go, the male predominance is 4 to 5 boys to 1 girl. It happens regardless of race, socioeconomic or education level. It has nothing to do with intelligence levels, begins predominantly between 2 and 4 years of age. It is individual and involuntary, and because there are no two people around alike, so there won't be two stuttering people alike. So we have to understand the individuality, and this is where it comes that concept that Gonçalo was talking about a minute ago. So we have to have a conception of a human being, and the human being is a whole and not just a mouth that doesn't work so well all the time. It is intermittent, and maybe this is the worst characteristics of stuttering, because today is, and a minute ago it was wonderful and now it's bad. It goes up and down very often, and this makes people think that maybe the person is too anxious or too nervous or too worried, and there is nothing to do with this. It has to do with dopamine and all the things that we probably have discussed, if not today, some other time. So intermittence is something that really drives a lot of people who stutter crazy, because it is hard to deal with, certainly. And it will vary, of course, from person to person, but retains these general characteristics and mainly will occur in families. But according to Dr. Shang, it does not follow a pattern of simple Mendelian heredity, and it's not caused by obvious deficiencies, neither cognitive, nor language, nor emotional development. It's no gross vein anatomy that we'll see in high resolution MRI, and lack of spontaneity in communication. Of course, it is hard to maintain fluency in this case. And the adverse impact on the person and their communication skills in various situations, it's different. Talking on the phone is different. Making a presentation like this is different. Every single situation of speech or communicative situation is different, and stutter will behave differently too, okay? It is hard to cope with speech situations, as well as reacting to negative responses from those in the speaker's environments. And the important thing is really, we repeat this every single time, the emotional reactions to the stuttering or the communication in general. Pay attention that the word important here is reaction. Reaction is a response to an action. I stutter, people react. And when we talk impact, we're talking about the reaction of the people who listen, somebody who stutters. And then the person who stutters has received back, what is this? What's going on? And, faces and expressions and things like that. So we have to pay attention about what drives our attentions: blockages, repetitions of sounds, syllable repetitions, or repetitions of monosyllabic words, prolongations. These things we can listen and see, but not necessarily, okay? Sometimes you just have larynxes that stutter, and we can talk about larynxes that stutter later on or in another moment. And then we come to cluttering. The first studies that were described began in 1917, and somebody, James Hunt, named cluttering, meaning confused and disorganized speech, and it comes from 1849, meaning it's a long time ago. In Weiss, this in 64, made a translation from Brooke in English so that it became more knowledgeable. And in 2007, there was the first World Conference on Cluttering in Bulgaria, and the International Cluttering Association was founded. And here in Brazil, we have described this as a very disorganized and confused speech, and Dr. Oliveira is the speech pathology that began with this work. And I also want to thank already for Sandra Jimenez, who helped me with those slides in terms of cluttering. So we have, it's not just a disorder of speech, but of language and communication as a whole, because it also involves reading, writing, prosody. Van Zalin says that fluency disorders, cluttering is a fluency disorder that the subject cannot adjust their speech rate to linguistic and motor demands. And Perron says that, sorry, Per, I just wrote your name incorrectly, but difficulty in adjusting speech rate related to functioning of the basal ganglia located inside the cerebral hemispheres. And these are very similar things to stuttering. So sometimes it's hard to differentiate one at the other. In the IC10, cluttering has a code that's 9F98.6, and believe it or not, this is the problem in the ICD-11, cluttering is within this developmental speech fluency disorders, but it's not, there is no way we could find cluttering in the ICD-11. If somebody does, please tell me. But it's class in the ICD-10, it says it's a fast speech rate with fluency breaks, and the speech is without rhythm, involving speech patterns with inappropriate pauses and decreased intelligibility. On the other hand, in the ICF, the 2007, they have descriptions of body functions, activities and participation, personal factors and environmental factors that will include speech fluency, rhythm, rate, all the inhibition, lack of monitoring, especially poor perception of symptoms, and usually runs in families because the most accepted etiology is heredity with a neurobiological basis. So that's why the ICD-11 says developmental fluency disorders is distinct from that disorder that we call specifically stutter, but in something like 35% or 33 or 1/3 of people who stutter also have cluttering, or vice versa. Okay, so you could find just stuttering, just cluttering, and both as comorbidities. So main characteristics of cluttering is a greater spectrum of clinical manifestation because it's a multidimensional and complex communication disorders because it will involve fluency, articulation, and language. It's a rapid and very regular speech rate. High frequency of important because here is one of the points that we can find problems. Difficulty in formulating language. It's a very disorganized speech with insufficient planning time, and which reduces the speech intelligibility. And it's very common to see what in the literature calls telescoping, which means we have the word articulation, but it comes something like articulation, or you just exclude phonemes like president, you'll see president. It's very compact, omission of syllables in words or presence of this phenomenon. It's called syllable coalescence, and it's a collapse of syllables, especially in multisyllabic words. Okay, there is also, we will find some abnormal lack of melody, syllable stress, or speech rhythm. By the way, it's very interesting, and I have been observing how difficult it is for people who stutter as well for people who clutter, how hard for them is to understand where is the main stressed syllable in the word, because these breaks in the rhythm and syllable stress just goes, they cannot identify them very usually. Pauses are made with the outside the linguistic markers, and the difficulties will migrate to reading and writing with repetition of words, revisions, and omissions of graphemes. And usually, I don't know exactly usually, but most in kids especially, may be associated with ADHD. And the thing that is especially different between stuttering and cluttering is that a very low self-perception of their speech conditions. Usually the diagnostics for cluttering is made from a third party. Somebody, when the person who stutters come to our clinic, they say, everybody says I'm talk so fast. I don't talk fast. They get very slow. People are very slow. I don't talk fast. They have the perception that they are just fine and the others are slow. So they do not have this awareness in the same proportion, for example, as people who stutter has. And so that we don't get, respecting our time, I just leave you here with the relevant aspects about speech in terms of differences between cluttering and stuttering. And So they have normal speech rate and typical of stuttering in terms of type of disfluencies. And they do not have awareness, but in this case, they begin to understand impaired intelligibility, and in stuttering is difficult to understand in keeping this. Muscular tension is low and cluttering, and very high in stuttering. The organization of thought and language here in cluttering is very difficult. In stuttering is not that difficult, and they have worries about multisyllabic words. And in stuttering, we have beginning of the words are really hard because 90% of this time stuttering begins in the first syllable, in the first sound of the word. In terms of monitoring of overspeech, there is a difficulty planning, a difficulty in organizing. It's very disorganized and impulsive, and in stuttering there's no little difficulty. And in terms of reaction to speech, the person who clutters usually gets irritated because he's not understood. And on the other hand, people who stutter has fear of stuttering. And we know fear is different from anxiety, for example. So people who clutter fear about multisyllabic words, and people who stutter has fear of words and sounds, and both have difficulty coping with the pathology, including social or personal insertion and integration. So these differences are important because when we do go to, maybe this person is talking too fast and have some little disfluencies. Normally, as disfluencies, the types of disfluencies are normal disfluencies. If I can say normal disfluence, like things, oh, it's difficult and different than repetitions or blocks or things like that happens in stuttering. Okay, so I leave you here with my contact so you can talk to me if you need, and I want to say thank you for inviting the Instituto Brasileiro de Fluência, and you can also find us. It is in Portuguese, but I know you can try that. And I want to thank Sandra for helping me with those slides because she's a great speech pathologist. And here we are. So now it's too fast, but ask me things.
Annalise, people are saying if you can put the slide with your contacts again so they can see it.
Oh, okay. Let me share this again with you. So, let's move here. Oh, no.
Yeah, I can move back.
Where is it?
I think if you go back,
yeah, I have to stop sharing and I have to open here here. Now, let's go and share. Oh, thank you for asking that. There you go. So you can email me or find me, and all these things, the social media exclusively for stuttering and cluttering, nothing about personal matters. So you can find me there. It's going to be, I'll be very honored.
So I have a few comments and questions, and thank you so much for for organizing everything with the literature. That is so important. I was thinking that there are two things that it's quite curious. One, usually when it's only cluttering, because we have a lot of stuttering with cluttering, but when it's only cluttering, they come to the clinical room and they say, people say that I stutter. That is something that someone who stutter will never say. So when the conversation starts with this, I always know that probably it's cluttering. And someone say that they are always getting stuck, and the other is about the experience and I'm thinking about adolescents that usually the experience of stuttering and cluttering is quite different. And one of the things that really annoy adolescents with cluttering, it's the parents are always telling them to slow down, slow down, slow down, slow down, slow down, slow down. And it's quite annoying. What do you think? This was a comment. Now my question, I don't know if you have this experience or thoughts on this. I saw with the pandemic, one of the nice things that we get from this huge experience with teletherapy, for a lot of people with cluttering, it was easier, our speech exercises, like in a Zoom call, because they can see themselves all the time, and the monitoring was so easy. I don't know if you felt the same thing.
Yes, adolescents are a very special case in terms of either stuttering or cluttering. First, I don't know exactly why, but they, in this age, they begin to speak faster, naturally, with or without a fluency disorder. And so if you do, and on top of that, have a speech disorder, then it'll be worse. But when they are able to monitor themselves, and that's what you said is right, if you see your face on the screen all the time, so it's easier to monitor. And you can see, for instance, if you stutter and you go to read a text that you don't know, you will stutter a lot more. But then if you rehearse, it'll be better. It's going to be at the opposite with cluttering. So there are certain differences in terms of diagnosis, but especially the amount of these fluencies. And in adolescents, we have to understand that they have this on top of the normal developmental things that happens with the community of adolescents, the teens. The parents say, why does he speak so fast with me and with everybody else? No. So parents think the problem is at home, maybe, but I guess it's part of their growing up process. But yes, when we monitor them ourselves, and stuttering, when you look at you on the screen stuttering, that the tendency is that they move away from looking at each other, because doing things like that, it's harder to see.
Yeah, that's true. I was also thinking that sometimes therapists are so focused on production, and we forget about the perception and how important it is to also work about perception and monitoring.
Yes.
And this is not exclusively for cluttering. Even in stuttering, if someone, and this is, I remember a sentence of Scott Yaris. He said that sometimes what we have to offer, it's not that appealing, like, because it's not that natural. But if you don't work naturalness, and if you don't work perception, people will not use what we are practicing. If you think about speech techniques. So, and in cluttering, probably it's worse than in stuttering.
Yeah, because the comprehension, because they it syllables a lot, so sometimes it's hard to comprehend the content, what was being said. With stuttering, it's also hard to understand the content sometimes when the stuttering is severe. But because we get distracted as people who are listening, the stuttering distracts us from the content, and all of a sudden you have to say, what? Can you repeat, please? Because our attention was diverted to another place. But monitoring is very important, and acceptance is very important. And I think that this is a problem that is not exactly emotional, but it's social understanding of what, and this is why we're here today, because to increase awareness about this. This is not a single problem. This is not just the mouth that stutters. It's a very important problem. We've been having lots of research that are trying to make us understand what happens in the brain, so that we can, science does research, and we have the obligation to transfer that into clinical procedures so we can help better people who stutter or clutter. It's a long way. We have a long time ahead of us, but it's so nice. We love to do it. And thank you for having this day, because we have to understand that people who stutter or clutter or how we're able, and that it makes their life a little better.
Annalise, thank you so much for your
Okay.
really, really great to have you. I know it's just so early in Brazil, but it's always nice to have your energy and your knowledge and your experience. And you can all see Annalise in our stuttering course and follow also her class there. Thank you so much, Annalise. Bye-bye.
Thank you. I thank you so much for everything. Bye.
So I want to thank you all for joining us this day. It was a great, great pleasure for me and my team to have you all. I hope we spread some ideas so you to think and also some resources so you can take a look on that and to improve your clinical practice. And it's great to have you all in this community that we all belong, that to share the word out, educate people about stuttering, improve our therapy, and be together and learning from each other. I think it's really, really great. So I want to thank you all, and please follow us at iStutter page. We'll have news soon, and I wish you all a great weekend, and of course, a great month of stuttering awareness in your communities. So thank you so much, and see you soon.